Hi everyone. So I couldn't make it to class today, so I'm going to do my presentation on the Berg balance scale just over this video. Just going to share my screen. Okay. Hope this works. Okay, so the Berg balance scale. This is an objective measure of a patient's ability to safely balance during 14 static and dynamic activities of varying difficulty. It was developed in 1989 as there was a need for a valid and reliable balance assessment, particularly for older adults and stroke patients, and is now used for a variety of reasons to assess non-vestibular static and dynamic balance, fall risk, and functional mobility. It is generally considered to be a gold standard for functional balance tests and is used in a wide range of settings, such as acute inpatient rehab, outpatient rehab, and home care. And it's used by OTs, PTs, and exercise physiologists. So the test was developed in 1989 by Catherine Berg, who is an associate professor at the Department of Physical Therapy at the University of Toronto. And it was published in a journal in 1989. And since that time, a short form of the assessment has been developed, and that was in 2016. And they're still doing research on it, but some studies have shown it to be reliable and valid as well. And the cost of the BBS is actually it's free, so you can download it from the internet in a variety of places, including if you use this link. And then this is just a picture of Catherine Berg. The initial target population for this assessment was elderly adults, mainly those who had stroke, who also had balance impairment. But this population has since expanded because they've done a lot of research in different populations, and it has shown to be a reliable and valid measure for adults 18 and older who have balance impairments and also who have a bunch of these different conditions that often present with balance impairment. So you have Alzheimer's disease, brain injury, intellectual disability, limb loss, just older adults in geriatric care, osteoarthritis, Parkinson's, pulmonary disease, spinal cord injuries, stroke, and vestibular disorders. And so clients, in order to use this assessment, have to be able to listen to verbal instructions or read the written instructions. In terms of normative data for this, it was developed initially for older adults. As I noted previously, the items were refined after administering the assessment initially to 38 people who were between the ages of 60 and 93 and who had a mean age of 73 and who had balance impairment. And for this first initial study that they used to get those norms, balance impairment was defined as having either had a fall in the past 2 months or having received OT or PT specifically to retrain balance. And there were no diagnostic restrictions. So when creating these norms, a lot of people had stroke. And yeah, there was no kind of restrictions on what diagnoses they could or could not have. They just had to have balance impairment. And so since its time of initial release in 1989, they've also had researchers collect data to get means or averages for different populations, including community dwelling elderly adults, chronic stroke patients, adults with osteoarthritis, adults with Parkinson's, spinal cord injury, limb loss, elderly adults with a history of falls, and elderly adults with dementia. Um, and those different scores can be found online at this Ability Lab website. And the assessment is standardized, and um, as noted, the scores are based on normative data. In terms of cultural appropriateness, the BBS has been formally translated into a variety of languages, including Chinese, French, German, Danish, Japanese, Spanish, Finnish, and the basic movements that are used in the scale, as you'll see if you look at the handout on the Berg scale, if you kind of go through each item, you'll see that the movements are pretty basic um, and can be understood by a wide range of people from different cultural backgrounds, which makes it pretty easy to translate. Also, a Greek version was recently tested and found to have excellent reliability and validity. There have been some translation issues that people have run into. There's specific terminology used like tandem stance, one-legged stance, an alternating foot, and look behind, which can be difficult to translate into a non-English language. So in terms of administration, this assessment is very quick and easy. It takes around 20 minutes to administer, and there's no formal training required. Um, some websites do note that the administrator should have some working knowledge of how to safely manage clients post-stroke and anyone with a history of falls, as these patients are susceptible to falling when asked to do certain movements, and they should be supervised. And when administering, you need some basic equipment, which people will just have to buy for themselves. There's a yardstick or ruler, a standard chair with armrests, a standard chair without armrests, a footstool or step, a stopwatch or wristwatch, a 15-foot walkway, and a slipper or shoe. The examiner is instructed to document each task and give instructions as written. And when scoring, they're asked to record the lowest response category that applies for each item. So this is just a list of the different measures. If you take a look at the handout I provided, just with the Berg scale on it, you'll get an even better idea of these measures. But basically, the movements that people are asked to do are sitting to standing, standing to unsupported, sitting with back unsupported, sitting to stand, or sorry, standing to sitting, transferring from a chair to another chair, standing unsupported with eyes closed, and so forth. People are asked to pick up an object from the floor while standing and to look behind them. They are asked to turn 360 degrees in a full circle and to do it in the other direction, to alternate feet on a step stool, to stand unsupported with one foot in front of the other, and to stand on one leg. So this is a video demonstration of how to administer the assessment. It's pretty clear from the instructions that you can just print out on the internet how to do it. It actually outlines exactly kind of what you would say to the client when they're performing the assessment. But I mean, some of the terminology, if you find any of it confusing, this video is really helpful. For time's sake, I won't play it, but if you are going through the assessment later and there are some items that you're a little confused by, I definitely recommend watching this. In terms of scoring, each item is scored on a 5-point scale. And then once all of the 14 items are completed, the individual scores are totaled. So a score of 0 indicates an inability to complete the task entirely, and then 4 indicates an ability to complete all of the task criteria. Um, and you'll see if you look at the Berg scale itself that the items are scored relative to time, level of independence, and supervision required. And points can be deducted for requiring supervision, assistance, or taking more time than allotted to complete a task. And the lowest category or score that applies for the client should be marked. So then for each item, you will be scored in a range of 0 to 4. And 0 is the lowest level of function possible, and 4 is the highest. And then once you total all of those scores together, you're going to get a score out of 56. And if the client scores less than 45, it indicates that the individual may be at a heightened risk of falling. The scores from this assessment can also be used to determine the level of mobility assistance that the client will need. So a score of 0 to 20 means that an individual will likely need assistance of a wheelchair to move around safely. 21 to 40 means that the individual will likely need some type of walking assistance, such as a cane or a walker. And individuals who score 41 to 56 are considered independent and should be able to move around safely without assistance. And in terms of relevance to the OTPF4, functional mobility is an ADL, and balance trading is also listed under health management in the OTPF4, and motor skills and vestibular functioning are also impacted by balance. And as OTs, we're going to have to assess balance and how it impacts overall functioning and well-being, and we're also tasked with recommending specific adaptive equipment to improve mobility. So scores from this assessment can help us determine how to proceed with some clients or enhance clinical decision-making. So in terms of reliability, the assessment is pretty reliable. It has high relative reliability, high inter-rater reliability, and intra-rater reliability in elderly adults. And this basically means that the test items have been found to be closely related to one another. Intra-rater means that the data is consistently recorded, the consistency of the data recorded by one rater over several trials. And then inter-rater measures the consistency of the data recorded by multiple raters over several trials or over one trial. Absolute reliability is the degree of variation in individuals who repeat the test. And it has been found to be stronger for individuals who score towards the high end of the scale and weaker as you get more towards people who score in the middle and the lower ends of the scale. So it seems to be a little bit less reliable for people who score lower on the scale. And part of that is because there just isn't a lot of data out there on people who have scored less than a 20 and whether if they repeat the test later, are they going to score really low again? So definitely more data is needed there. And in a systematic review of clients in rehab for stroke, it was found that the assessment had excellent inter-rater reliability, intra-rater reliability, and test-retest reliability, and good internal consistency. In In terms of validity, content validity, or the extent to which this assessment actually measures balance and impairments in balance, was established when the assessment was developed. So, a bunch of healthcare professionals worked to kind of refine the questions that were asked and to ensure that they actually were going to be a good measure of balance impairment. They did that during a three-phase process. Um, and in terms of convergent construct validity, um, this refers to how it correlates with other measures of balance. It has been found to have excellent correlations with other balance scales, such as the Barthol Index and the balance subscale of the Fugl-Meyer assessment. And also, it has good predictive validity because high scores on the assessment are related to a higher probability of discharge from hospital to home. There are some studies out there that also support the test's ability to predict falls, though findings are mixed on this. It has been sort of used less and less to predict falls just because some research has come out recently that says that it might not be a good predictor of that. So these are my evidence-based articles. This is a systematic review of its usefulness in stroke rehab. So basically, researchers examined the psychometric properties of the assessment and its strengths and weaknesses when used with stroke patients. And they specifically took all these findings from 21 studies that had researched the assessment with stroke patients published between 1966 and 2007. And basically, they summarized all the findings from these different articles and determined that the assessment has strong reliability, strong validity, responsiveness to change, and is useful and easy to administer. It also has good predictive validity for certain outcomes, but is not a good predictor of fall risk post-stroke. And some limitations of this is just that, it's only based on 21 studies and more research is needed. And the clinical significance of this is that for OT practitioners, it can be used as an effective measure of balance impairment in stroke clients, at least based on these findings. And practitioners should be less confident in its ability to accurately predict falls in clients post-stroke. So this is another systematic review, and I also mentioned some findings from this in the previous reliability slide. But basically, the purpose of this systematic review was to determine the reliability of the Berg scale across all clinical populations, not just stroke. And researchers selected databases for studies that were published between 1980 and 2010. And the relative intra-rater and inter-rater reliability was found to be high, and the consistency of scores in individuals with the absolute reliability varied more. And again, as I mentioned, it was more reliable for individuals who scored high, who didn't have severe balance impairments. Some limitations was that this review only included people with moderately poor to normal balance. So there definitely should be some more reviews that are more extensive, that have a lot of different scores. And the Berg scale is able to detect many clinically significant changes in balance with 95% confidence, but more data is needed, specifically to measure how reliable it is in clients who are at the lower end of the scale. So, in terms of relevance to clinical practice, this scale is used by occupational therapy practitioners across the care continuum. It is essential, balance is essential for performance of most activities of daily living. An impaired balance can lead to increased risk of falls and decline in daily functioning or performance of ADLs. Scores from the BBS can be used to justify the need for mobility aids, to predict fall risk, and to determine the most effective treatment interventions, and also to identify safe and unsafe activities for people following an injury or illness. And it should also be noted that balance is subject to change as you kind of go through rehab. And this serves as a quantifiable measure that clinicians can use to monitor changes in progress and to adjust treatments accordingly. The assessment is reliable in assessing functional mobility and can be used with a variety of patient populations. It is quick and easy to administer and commonly used. Um, it does not measure quality of gait and therefore might be less useful than other balance tools if motor control is the main contributor to poor balance. And most available research on the BBS has been done on elderly adults. Um, so definitely more data is needed. Findings from a few studies suggest that it may not be an accurate measure of balance for individuals under age 75. More research is also needed on its use as a predictor of falls. Okay, so that's my presentation. This is now a hands-on activity that I'm going to ask you guys to do. So if you could just pair up with a partner um, and just take some time to review the Berg Balance Scale, the general instructions and the different individual measures, and then just pick a few different items from the scale to practice with your partner. I'm going to have you do a little role playing. So if one person could act as a 75-year-old female with a history of falls who recently suffered a stroke and who has left-sided hemiparesis. Um, and the other person will play the occupational therapist who is tasked with administering the Berg balance assessment. As you practice, take time to consider the following questions. What are some clinical precautions that OTs should adhere to when administering the BBS to post-stroke clients? What adaptive equipment might you recommend if a client receives a score of 30, which indicates a moderate balance impairment on the BBS? And what evidence-based interventions do OTs use to improve balance in clients following an acute injury or illness? So yeah, just take a look at the handout that is provided and kind of just try to familiarize yourself with the assessment and practice administering for just a few minutes, 5 or 10 minutes. And then these are just my references. And that's all. Thank you guys.